Hey everybody, Dr. Danthler here with Beltline Health, bringing you the newest video to explain weight loss surgery. In today's segment, we're going to end up talking about the gastric bypass, how it works, risks and benefits. Just to bring you up to speed, if you're joining me for the first time, in the previous video, we did talk about, first of all, why people struggle to lose weight. We talked about metabolic adaptation, how we have evolutionary mechanisms that really prevent us from losing weight once we put the weight on. Then we talked about the sleeve gastrectomy, how it works, its risks and benefits. And we talked about an associated hiatal hernia repair. If we find that you have a hiatal hernia at the time of the sleeve, we want to fix that so we can hopefully reduce the risk of having an unwanted side effect of reflux. And now, like I said, we're going to talk about the gastric bypass. Most people refer to the RNY gastric bypass as just the bypass, but just so you know, this is the full name of that surgery here, and you can call it the bypass, and we'll know what you're talking about. Alright, this is a picture of the RNY gastric bypass, just to orient everyone and review a little bit. What we have here is the esophagus, which brings food down that you've just swallowed, chewed a little bit into the stomach. And remember, again, I'm going to go into the details of this diagram, but just to review again, normally when you eat food, food travels over here after being processed in the stomach a little bit and mixes right here. So this is what I will later refer to as the critical mixing point. It's where bile from the liver and enzymes from the pancreas meet that food for the first time. Unless that mixing happens and there's an actual chemical breakdown of the food, you don't absorb it in its macronutrient form, the things that we always talk about when we're dieting: proteins, carbs, and lipids. So that critical step happens right here, and I'm about to show you how this surgery is different from the sleeve, because in addition to doing what we call the top half surgery, where I impart change on the stomach to create restriction, we're going to add something called malabsorption by manipulating the intestine. So let's talk about all that. First of all, this surgery can be done with 6 incisions. The sleeve is done with 5, but again, we do this laparoscopically and robotically. You're looking at about 75 to 105 minutes to perform on average. I always like to say surgery takes as long as it needs to be done safely. We're not in a rush here. Now, for the first part of this surgery, like I said, the parts of the surgery where we act on the stomach typically are restrictive. As I indicated with the sleeve, they can also be metabolic, and that is also the case with the gastric bypass, but mainly we classically talk about a restrictive part of this procedure being the creation of this pouch. It ends up being a teacup size pouch, or really a large egg size pouch, where now a couple of bites of food can hit that, give it a good stretch, and make you feel full. From there, the second part of the surgery involves dividing and rerouting intestines. So we come down here to the small intestine, we cut and divide it, and then I reroute that so that it's connected to the pouch directly up here at the top. In doing so, I've now created a scenario where food you've eaten can travel directly into the intestine and travel a couple of feet of intestine without being processed or broken down. That is different from when food traveled over here and mixed very early in the digestive process. I essentially create a situation where now those critical enzymes, which have to break down the food, have to act on the food, don't meet up with the food until further downstream. A question I usually get around here is how much intestine is removed. Well, intestine isn't removed, we've simply split it and redirected it so that, again, the enzymes just meet up with the food later, and food enters the intestine at an earlier point than it normally would. In doing so, we change that critical mixing point. I'm going to indicate that with a star. I already talked about it, but normally food, red arrow, would have traveled down a normal stomach, or in the case of a sleeve where we don't manipulate intestine, into this first part of the intestine here to start mixing with those enzymes. But after rerouting things, I essentially changed that mixing point from up here to down here. So now this is the new mixing point. This is the first time food you've chewed and swallowed is mixing with those enzymes, and you can very physically see how that has shifted down further away from the stomach. In doing so, we also inherently change something else. We reduce the length of the intestine that's left over from the mixing point. So normally, I also gave you this critical number in previous lectures. Normally when mixing happens from this point to the end of the small bowel, where it connects to the colon, which I'm pointing to right now, is about 16 to 20 feet for the average adult. By changing the mixing point, I have reduced that bowel length over which we now have surface area to act on the mixed food and enzymes from a length of 16 to 20 feet down to about, I estimate, 10 to 12 feet, depending on how aggressive we are in the bypass. I also think, historically, we described weight loss from the bypass as similar to the sleeve, which is really weird because this is a much more aggressive surgery. And I think some of that, I personally think some of that has to do with how surgeons are doing the surgery and how much intestine they're bypassing. Some of it is unknown. Remember, it's a wide range, 16 to 20 feet. 4 feet is kind of a big deal, so we don't typically count all of the intestinal length for everyone. So if you have short intestine and we bypass the same amount every time, you're going to effectively end up with a shorter, this is called the common channel, than someone who had longer intestine. I think because there's such a degree of variability in the patient's bowel length and in how surgeons do it and how much they bypass, statistically speaking, weight loss, especially in the first year, tends to be the same. But I do think in special circumstances, if you're someone who needs longer bypass, but you need some of the other benefits of a bypass, such as better rate of diabetes resolution or more weight loss, that we can do things slightly differently to control how much bowel we bypass and how long we leave your intestine. But as an average rule of thumb in describing these surgeries and to keep it, have a way to remember for you as the patient, I tend to say that we leave you with 10 to 12 feet of intestine from that mixing point. And there you go, that's the intestine left after mixing. And this second part of the surgery specifically is what we call malabsorption. So the bypass is different from the sleeve. Classically, we describe the sleeve as strictly restrictive, just doing the stomach part of the surgery. I think there's we now know that there is actually a metabolic component to that. And now with the bypass, we're adding this second half of the surgery where we are creating a malabsorption. Malabsorption means bad absorbing. So we've created a situation where it's harder for you to absorb calories. In addition to eating less, your ability to absorb the calories out of what you ate is reduced. That's called malabsorption. Okay, moving along, just to bring everything home. Let's talk about the benefits of the gastric bypass. We talked about how it's restrictive with that top half surgery, tiny pouch, egg size for reference. It's also malabsorptive, as I showed you in detail with the diagram, without removing intestine, effectively giving you less surface area, a shorter distance over which the mixed food and enzymes can act and calories can be extracted. We also know that by bypassing that initial segment of the intestine where the mixing point is, we do get a decrease in certain gastric hormone production and other hormones. We know when we remove the stomach and the sleeve that we get dramatic reduction in ghrelin levels, for example. There is There are other named hormones and peptides that, because the food doesn't get exposed in that first part of the intestine, we know that levels of those hormones and peptides go down as well. I'm not going to go into details about what they are here because it can get overwhelming and too detailed, and I don't think you need to know, but there is basically a metabolic component to the bypass too without removing stomach, so I wanted to make that clear. Again, at 3 years, 60 to 80% excess weight loss after gastric bypass. That number is technically the same as the sleeve, slightly nuanced, but I do think it's important to say that while initially weight loss may be the same, and historically weight loss between the two was the same, I think because of how the surgery is being done, I feel safe in saying you're more likely to hit those higher numbers, that 70 to 80% range with a bypass, than you are with a sleeve. I think younger patients tend to get similar results between the two because, again, you're coming to the surgery with fewer medical problems. Typically, if you're younger, you have a higher metabolism because you're younger. Maybe you have more energy, time, absence of back or knee pain, so you're getting more exercise benefit, which can really drive those sleeve numbers to be similar to a bypass. But if I'm seeing you and you're already over 50, you got beat up back and knees, you're not going to get as much exercise benefit as someone that's younger than you. I would feel more confident telling you that you're going to push to the higher expected weight loss with the bypass than the sleeve. So keep that in mind. And there it is, what I just said in bullet form. But also, when you look at weight loss over long term, on average, bypass does get people 8% more weight loss than the sleeve. And here's the real reason that bypass is an advantage. And in selection criteria, this is how I tend to word things. If sleeve and bypass are similar in what you can expect for weight loss, then the true advantage of choosing a bypass in your weight loss journey would be, in my mind, in order to have a better diabetes resolution rate. It is superior to the sleeve in curing longer standing diabetes. So anyone who's now at a level where they're on insulin, maybe not just a metformin or a single drug. I just got diagnosed in the last year or two, I'm not on insulin. Data says that if you're early diabetic like that, just on an oral agent, probably sleeve and bypass are similar. But definitely if you've had longer term diabetes and you're on insulin, the bypass is superior. So I may be pushing you to think strongly about the bypass. It's also the superior option for reflux. Remember, after a sleeve, there's a 20 to 30% risk of developing de novo or new reflux or worsening reflux. If you're coming to see me and you already have reflux, you're on an antacid medicine, I'm going to try to steer you away from the sleeve, especially in the absence of a known hiatal hernia or something we can act on. I think the bypass is going to be the best option for you to keep that at bay or cure it. Increase your chances of coming off a lifelong antacid medication at the same time as addressing your weight. So, you know, if those two things matter to you a lot, we want to really emphasize that the bypass has a clear advantage over the sleeve for those two reasons. In terms of what to expect after surgery, it's the same as a sleeve these days, 1 to 2 night stay. And really that should be a 1 night stay. 90% of patients aren't staying more than a day after their surgery for a sleeve or a bypass for that matter. Alright, let's move on and talk about the potential complications after gastric bypass. So leak, 0.5 to 1%, similar to the sleeve. I will say there's more areas where we cut things. So the stomach pouch, where we divided intestine and connected it at 2 different points. Each one of those has a slight 0.5 to 1% leak rate. They're not perfectly additive, so I don't want you to think like, oh, now I have a 3% leak risk. It tends to stay in that 0.5 to 1% range, but each site does have a slight chance of a leak, so keep that in mind. Something called a stricture can still happen, especially where we connected bowel to that little pouch. It can become this narrow little opening that can make it hard for food to move through, trouble feeling like You may feel like things are getting stuck. That's rare because we do this pouch over, again, a calibrating, we call it a bougie. We make sure that connection is at least 3 centimeters, and we're seeing less of that. Here at Beltline Health, all of us surgeons hand sew. We use a hand sewn technique to calibrate that, and so that tends to be a little protective for strictures, in my opinion and experience. Ulcers. Now this is a unique complication for the gastric bypass. So when you sign up for this, in my mind, everything else being about the same, one of the unique risks that you'll carry for the rest of your life, actually, about a 2 or 3 to 5% risk of forming ulcers. They tend to happen up at, imagine on that picture I showed you at the top, right where the pouch is connected to the bowel. We call it a marginal ulcer. People who get that tend to be smokers, so don't smoke. By the way, if you smoke, we're not going to let you come to surgery, so just keep that in mind. And the other thing, people, and this is worth remembering, it's really just an education point. Once you've had the bypass, you're at risk for ulcers if you take NSAIDs. Those are Advil, ibuprofen, Aleve, Motrin, Goodies and BC powders, those types of drugs. That class of medication can be very irritating. It can cause you to have an ulcer. If you took it once in a while, the chances of you getting an ulcer is rare. But if we're talking about which surgery you want to pick, you're already on those meds pretty regularly because you have bad knees, bone-on-bone knees, or bad back, then we may steer away from it because you're really relying on it. On the flip side, the patients that typically end up having an ulcer issue, it's not in the first couple of years, it's like 5 years down the road. You've lost the weight, you've gotten comfortable, maybe the fact that you had a bypass is in the back of your mind now, and then you twist an ankle or something playing with your kids or grandkids. You forgot that Dr. D said don't take those NSAIDs routinely, or you'll run into a problem, and you reach in the cabinet and you're taking Advil, ibuprofen a lot. You take it 3-4 times a day for like a week straight, I can almost guarantee you're going to get an ulcer. So as long as you remember that Dr. D said that about your bypass, you call us, ask for alternative medications, talk to your orthopedic doctor about medicines other than NSAIDs to deal with the inflammation, or ask for, there's prescription strength anti-inflammatories that do protect the lining of the stomach. Something like that in limited doses ought to be safe, but that's really what you need to be aware of as far as ulcers go. The other thing you can get anytime we start manipulating intestine, cutting, dividing, and connecting, that specific point where I said we change that mixing point to, that's an area where you're at slight risk for an internal hernia or obstruction. That's about a 1 to 3% lifetime risk of forming an ulcer, obstruction. But it's a small risk, and still there's many benefits to offset that. Last but not least, I don't call it a complication, more of a side effect, something called dumping syndrome. This is an intolerance of high sugar or high fat foods due to that anatomic change we made to the intestine. The intestine doesn't like seeing unprocessed, unmixed food, so it can cause these side effects or symptoms like nausea, vomiting, diarrhea, abdominal cramps and pain, flushing, dizziness, lightheadedness, high heart rate. I actually think this is an advantage of a bypass, and it's why we may see more weight loss with it and more durable weight loss. The first time you have dumping syndrome, you're not going to want to experience that again. Guess how we treat dumping syndrome? 99% of the time, it just needs coaching, being re-educated on how to eat properly with the dietitians, chewing well, eating dense protein, staying away from carbs. Don't wash them down with liquids because you're going to flush that into that intestine. 90% of the time, that's how you handle it. We do have medications if you're having breakthrough dumping syndrome side effects despite eating properly. So not too problematic. It can happen if you don't eat properly, but once it does, it can actually be something that coaches you into eating properly, and eating properly for the rest of your life, which is what you should be doing. Malnutrition, just like the sleeve, we run the risk of getting low on key vitamins and nutrients. We overcome that by taking vitamins. Listen, we want to get you off of all your chronic medications, but think of it as a trade-off. I'm getting rid of a handful of diabetes meds and hypertension meds. Now I got to take 2 to 3 vitamins. once we start adding malabsorption to your surgery, that risk of malnutrition does go up. So whereas with the sleeve I say 1 to 2 vitamins a day for the rest of your life, with the bypass I tell my patients be ready to take 2 to 3 vitamins a day for the rest of your life. And going a few months without those vitamins can really give you some serious side effects and problems. So more important to be diligent with the vitamins. Come and see us and get those levels checked. All right, everybody, we've talked about the gastric bypass, and I hope you found this eye-opening, educational. I hope this helps you make the decision that's best for you in surgery. At the end of the day, we do want our patients to pick their surgeries, but it's our job to educate you and certainly kind of guide you in the right direction. And I hope you found this talk on the gastric bypass to be helpful in making that decision for you. As always, stay tuned for more content. I'll just tell you, I'm going to be working on a video on the duodenal switch next, and of course the SADI operation, the newest weight loss surgery. And I'm going to talk about the risks and benefits and how those surgeries work. As always, follow us on Instagram and Facebook at Beltline Bariatric. And of course, me personally, if you like the way I talk about things, you can find me at Dr. D Surgery on all of the social media and YouTube platforms as well. So have a nice day out there, stay healthy, and stay tuned. Thanks.